Thank you very much for the nice introduction. I do see some familiar names on the group here that's gathered to hear about this. So nice to see you, and also nice to meet the rest of you who I may not have met before. As mentioned, I'm Kathleen Nadelgaze. I am a pediatric emergency medicine physician and EMS physician in Colorado, and I'm also working with the EMS for Children Innovation and Improvement Center. And it's through this work that I have become involved in pediatric readiness for EMS agencies. So I was asked to kind of speak about how can pre-hospital readiness kind of support rural EMS clinicians, and also give guidance or support or resources to your programs that are working for recruitment and resilience among your EMS clinicians in rural communities. So with that, I just actually, when I was asked to give this lecture about a week before, we had actually received this email from the EMS for Children Innovation and Improvement Center. And it's always kind of heartbreaking to get emails like this and really think about what would be appropriate next steps for outreach and support. Following a tragic accident involving an aerosol can explosion, my young child suffered facial burns and had to be intubated by rural EMS responders. Due to a lack of pediatric equipment and training, he was intubated with an adult-sized endotracheal tube. That one moment led to unnecessary time on a ventilator, scarring in his airway, a readmission after discharge, and multiple procedures. What nearly took his life wasn't the fire, it was the lack of pediatric readiness in our local EMS system. And that is a verbatim email speaking directly to pediatric readiness. And so there are many well-known gaps in pediatric experience among EMS agencies and EMS clinicians, and many of these initial published studies are actually 2 decades old, but the data really is not that different today. So a study in 2000 by Glaser showed that 87% of basics, 84% of advanced EMTs, and 60% of paramedics treat fewer than 4 children a month. 80% of EMS agencies nationally see less than 8 children a month. That's 1 every 3rd day. ALS providers in Houston, when they were reviewed, about 33% had probably in their lifetime as a practitioner performed CPR on at least 20 children, but the majority, basically 3/4 had performed CPR on less than 5 children in their career. Similarly, individual ALS providers in Boston deliver bag mask ventilation once every 1.7 years. They intubate every 3 years on average and put in an IO every 6 years. And so Boston's a pretty busy, big city where there are a lot of people and a lot of calls. And for an individual ALS provider to have that little experience in caring for an acutely or critically ill child is notable. Dr. Marion Gaucher-Hill, who really is the leader of all of this work that I'm talking about today, found that it would take about 20 years for every paramedic in 11 counties in California to perform bag mask ventilation at least once on a pediatric patient. And also many studies show that the underutilization of acquired skills leads to undertreatment of children. Because EMS clinicians don't have experience caring for children, they often don't do things. So there's less use of medications for pain, less administration of epinephrine and anaphylaxis, just overall under-treatment of children as a whole. And then finally, even though many EMS agencies may require pediatric advanced life support or some other kind of ongoing pediatric education, the majority of experienced paramedics would not be able to pass a test on PALS concepts 2 years after certifying with PALS, and PALS only requires recertification every 2 years. So a lot of information kind of drains out of the brain when they don't use it on a daily basis. So, what happens when a child is really, really sick and a pediatric hospital is far away? What we know is that pediatric readiness in hospitals matters. This was one of the initial studies that really showed this. Stephanie Ames and her colleagues published on 426 emergency departments across 5 states, and they looked at outcomes of over 20,000 critically ill children. And they used pediatric readiness scores of those facilities to kind of identify risk of mortality. And what you can see there is that the baseline lowest quartile of pediatric readiness, if you use as a baseline, children in the next upper quartile had 1/2 the mortality. Critically ill children in the third quartile had 1/3 of the mortality, and critically ill children in the highest quartile of pediatric readiness had 1/4 the mortality. So there's a clear dose response here with regards to mortality in critically ill children. And then in follow-up, at the last couple of years, there's been a slew of publications by Dr. Craig Newgard, who took the 2013 EMS pediatric readiness, or not EMS, but national pediatric readiness data from hospitals and did a series of studies really linking to outcomes. In one study looking at 832 emergency departments and almost 400,000 children, they looked at in-hospital mortality and found that children from the highest pediatric readiness facilities had 1/2 the mortality compared to those in the lowest quartile. Similarly, they also found that when they compared medically ill children and injured children and examined their risk of mortality separately, injured children had 60% of the risk of mortality, and critically ill, medically ill children had 76% lower odds of in-hospital death in high readiness emergency departments. These were sustained, as you can see, that over time, days from initial ED visit, there was a slight increase in mortality overall, but these differences were sustained a year out. So what brings me to present to you? Well, we've heard from EMS clinicians that readiness really does improve their resilience. And resilience will improve recruitment and retention. When people are not burnt out, when they have resilience on the job day to day, it's easy for them it's easier to recruit, and it's also easier to retain. People don't want to leave their job, leave their field, their career. And we certainly saw this in the COVID pandemic, which also led to the Great Resignation, across emergency care providers nationally. So a few years ago, EMS for Children and HRSA led a collaborative among 9 states to really start to increase the number of pediatric emergency care coordinators in EMS systems. And as part of that work, we were able to do some focus groups and structured interviews with many of the clinicians. And these are just a few of the quotes that we've heard about the importance of readiness in their systems and their experience. It's scary, it's not that glamorous, and it's not something anybody wants to think about. When you mention a pediatric code or something like that to certain people, they shudder. Another one about a call. We prayed we didn't have a pediatric call because we run only maybe 10 calls a year. Most of the guys are really not comfortable. They're wanting to know more and more to make sure their skills are still as good as possible. And then finally, a couple of weeks ago, we were called for a possible pediatric drowning. We were able to get his pulse back and he survived a little over a week. It was important to know that we did everything possible that we could to improve this patient's outcome. So EMS clinicians are very aware of their discomfort with children, and they really impart to their leadership a goal to be more prepared for kids, to basically have their agency be pediatric ready. So, who can help our systems improve? I'm really here kind of on behalf of the EMS for Children program. The EMS for Children program is one that has focused on the entire continuum of emergency care, trying to build systems based for adults to care for children. And so it's specifically came about in the early 80s. As a program designed to reduce childhood death and disability due to severe illness or injury across the entire emergency care continuum, from initial response, pre-hospital and hospital-based care, and any inter-facility transport, rehabilitation, and injury prevention. And it really focuses on putting increased pediatric capability onto existing emergency care systems that historically have not been designed for children. And this is an example of the timeline of pediatric readiness through the lens of the work that HRSA has been doing and the EMS for Children program has been doing over the last 2 decades. There was an initial generation of EMS performance measures in 2006 that were released that really started to kind of get a better sense of what is the general capacity for pediatric care in existing emergency care systems, including what percent of EMS agencies had access to pediatric offline protocols, what percent of EMS agencies had access to pediatric online medical direction, what percent of EMS agencies had all the recommended pediatric equipment. Those were examples of some performance measures that were initially evaluated with the goals of state partnership programs to kind of support and improve these numbers over time. In addition, in 2006, there was a set of key publications out of the Institute of Medicine, which is now the National Academies of Medicine. And those publications really spoke to how the emergency care system was somewhat broken in the US and definitely not well established to care for children. Following the performance measures and those initial statements, there was a series of things in partnership with national organizations, including the American Academy of Pediatrics, to kind of create policy statements on what does a hospital need to look like to be pediatric ready. And that initially came out in 2009 and has been revised and updated and is a still standing document to this day. There were a series of targeted issues grants funded by the EMS for Children program that were really focused on pre-hospital care specific for children. And then the National Pediatric Readiness Project officially launched about 3 years after that initial COPEM policy statement. And that really is where a lot of this data that I just shared about the importance of pediatric readiness comes from. The NPRP, as we call it for short, is a comprehensive set of guidelines and recommendations and criteria that hospitals and emergency departments should do to be pediatric ready. And it forms the basis for which many state partnership programs across the country use as criteria for their own pediatric readiness assessments in their own states. In 2016, the EMS for Children took a bit of a left turn, and it was really to kind of focus more on quality and process improvement. And so they funded the EMS for Children Innovation and Improvement Center. And this center has really led a series of collaboratives to kind of help hospitals be more pediatric ready. It also has a pre-hospital domain, which leads the National Pre-Hospital Pediatric Readiness Project. The bulk of the work originally over the first basically now 10 years of the EIC is really, again, providing technical assistance to state partnership programs and really supporting this readiness work across the country. In 2017, as part of this timeline, we really evolved from kind of counting what percent of agencies have this, what percent of agencies have that among EMS agencies, and we moved into a second generation of performance measures, which is a little bit more qualitative. What percent of agencies do pediatric skills checks and have some process to measure competencies with equipment? What percent of agencies have systems in place to really be pediatric ready, i.e. The presence of a PEC and things like that? And then finally, in 2020, the Pre-Hospital Pediatric Readiness Project, or the PPRP as we call it, was officially launched. And this project came on the heels of another COPEM policy statement that was a joint statement. COPEM stands for the Committee on Pediatric Emergency Medicine, and it's a committee supported by the American Academy of Pediatrics, in case some of you might not be familiar with COPEM. The American Academy of Pediatrics joined up with the National Association of EMTs, the National Association of EMS Physicians, the Emergency Nurses Association, and the American College of Emergency Physicians to speak to what does an EMS agency need to do to be ready for children. And there was a series of recommendations that came out of that. One thing I will point out is 2 key performance measures we are still measuring today for EMS agencies include what agencies have a PEC and the skills equipment there. So just as an example of the joint policy statement, it's currently being reviewed and will be re-updated in the coming year with new data on what matters in emergency medical care of children that will kind of inform additional recommendations coming forward. So I wanted to share this with everyone here on this call. I know that the Medicare Flex program is not in every state, but in fact, every state has an EMS for Children program and all territories as well. The colors show kind of where those programs are housed. Many programs are in a state EMS office, the large majority of them. Some are in a Department of Health or a different state office. Those states that you can see in blue are where it's housed either in a school of medicine or a children's hospital. And then there's been one state that has not had a program in a little bit. So if you ever want to determine who your point of contact is for your state EMS for Children program, you can go to that QR code there. You can then select your state, and then when you select your state, it'll bring you to the grants contracts or contacts for your EMS for Children program. Every program has a program manager who is the main point of contact. Every program has a project director or principal investigator. That's my role in Colorado. And every program should have a family advocate member as well. Those are key members of the program that really help lead the work to kind of make sure that there's connection with every EMS agency, every hospital, and even stakeholder communities to support families in their state. These are those current performance measures I was mentioning, these are our newest performance measures that have just come out in 2023. And again, we're still focused on what % of agencies have a pediatric emergency care coordinator. And there's real data that having a PEC is meaningful, and I'll share that with you. There's also a goal that all EMS agencies have a disaster plan that includes pediatric considerations. And then finally, what % of EMS agencies are verified as a pediatric ready agency by a statewide recognition program. The hospital performance measures are somewhat similar. What % have a PEC, what % are verified as pediatric ready in a statewide recognition program, and what % have a disaster plan. And then finally, there are just general goals to kind of really establish permanence for EMS for children in the community and in the state and territory, and to expand the family network and improve collaboration of EMS for children with other programs, which is part of why I'm really happy to be here today. So I'll talk over the next few slides and minutes about the National Pre-Hospital Pediatric Readiness Project, which you can see here is a logo related to every organization that has a footprint on this project. It is really a labor of love. And the fact that 20 different organizations and federal partners all have active representation in a steering committee to provide oversight of the project and guidance is really a testament to the engagement and desire nationally that we have to improve pediatric readiness for EMS clinicians every day. So the joint policy statement that was originally published in 2020 provides guidance and specific recommendations around several different things. One is a recommendation for planning and collaboration of EMS agencies with medical professionals, public health experts, and families, that all EMS agencies should have pediatric specific direct and indirect medical direction. All EMS agencies to be pediatric ready should have considerations of children and family and emergency preparedness and planning. That there should be pediatric specific education, including the unique developmental aspects of children. This is critical so that EMS clinicians who are taking care of children who are either neurodivergent or nonverbal still feel empowered and know how to take care of kids that are growing and different than the average adult that they see. And then additionally, there should be pediatric specific equipment and supplies available. And this really comes from a national set of recommended equipment that includes pediatric equipment. Additionally, there is recommendations to get down to the nitty-gritty of process improvement for the EMS agency, specifically practices to reduce medication errors, such as using volumetric dosing guides, pediatric specific measures in periodic quality improvement and quality assurance processes, tracking of pediatric centered outcomes, and patient and family centered care and culturally competent care. And then finally, the safe transport and destination considerations for children. Again, there are many national organizations and national policies to really kind of provide white papers and recommendations. And our goal is to kind of make all this available through the Pre-Hospital Pediatric Readiness Project so that agencies don't have to go looking elsewhere for this, given that these are the recommendations that are out there on what they should be doing to be ready for children. We have a checklist, and the checklist is based on these domains of care that I kind of provided a little bit of more in-depth recommendations on. And really a lot, as you can see, that first column of the checklist, and it's a two-page checklist, so there's a backside to this. The column on the left is really all about education and competencies, and the education and competencies are not just knowledge of pediatric clinical care and competency with pediatric equipment, but there's also affective competencies as well. And that's ability to communicate, ability to understand children's developmental stages, and stay kind of present in the moment and be able to continue to care for that child no matter what is kind of rising up in them that is stressful. There's recommendations around the equipment, medication and patient safety, family-centered care, policies, procedures, and protocols, quality improvement, and then finally interaction with systems of care, which is really seeing EMS as part of a larger system of care. So collaboration with hospitals, collaboration with public health, collaboration with healthcare coalitions, and disaster preparedness. The additional thing that we have is a toolkit, and the toolkit has about 200 resources available to EMS agencies across all of these domains. We revise each section at least annually. We just had our toolkit meeting and are making a whole bunch of changes around dispatch to the toolkit right now. When there are old resources or things that don't work, we remove them. If there's new updated information, new evidence, new recommendations, we add it to the toolkit so that it's really a living, breathing resource for EMS agencies. We have a short video. It is a little overwhelming to go to a web page and be bombarded with 200 different items. So there's a short video to help users kind of figure out how to navigate it. It is multimedia in nature with video, simulation templates, checklists, and other things. So the toolkit is really one of the big deliverables for the PPRP that we're particularly proud of. And then finally, the main key component of doing pediatric readiness CMS agencies is you need to be able to determine what is the state of readiness. And that included doing an assessment. So similar to those pediatric readiness scores for emergency departments, which show that a higher score is associated with decreased mortality, we did the very first national assessment of pediatric readiness on EMS agencies across the country. We created a score based on questions, and these questions were weighted based on the considered importance. And you can see the weighting there where education and competencies are really seen as key and important, in addition to pediatric role and coordination of care and patient and medication safety. What's also key to note is that there are some agencies that may be BLS agencies only and not ALS agencies. And there might be certain factors or treatments or recommendations asked in this assessment that might be out of scope for a BLS agency. That being said, we determined that almost 92% of the total possible points were related to overall agency readiness, independent of scope of practice. So in our analysis for BLS agencies, if they get a score of 92, they are as ready as they can be, in a sense. We completed the first national assessment of pediatric readiness in July of 2024. Out of the 15,000 agencies that we surveyed, 7,000 responded. We currently are undergoing a big, massive review at both the national level and also at individual state levels on the scores and readiness of EMS agencies. And that data is currently being reviewed and will be released to state partnership program managers shortly, so that they have tangible data on how to proceed. The percentages that you see there on the right among those states kind of show the overall percent of EMS agencies that completed the assessment. We do know that we also are assessing which specific agency factors are associated with high readiness. That information will be really valuable to state partnership program managers, state offices of EMS, to kind of help give guidance to what agencies can do. Particularly, we wanted to look at factors that were modifiable. It's very hard to modify how many kids are in your community. So we didn't want to specifically look at things like PEDS volume as a factor, because people cannot make more children necessarily in their community, so that EMS is more ready for kids. Our next steps are really to validate these scores against patient outcomes. And there's an investigator out of Oregon who has some funding to begin to do this exact work. So while we're waiting for this data to be available to us, the question becomes, what can you do? What can EMS agencies do? What can states do right now? So I'm just going to round back to pediatric emergency care coordinators. These are individuals that were called for in that series of reports that came out in 2006. It's recommended that every EMS agency and all emergency departments designate a pediatric emergency care coordinator. The goal being that they oversee pediatric care and quality improvement initiatives. They provide skills training to agency staff, and that they assure that the medications, equipment, and supplies needed for children are available. It is recommended that emergency departments actually have two PECs, both a physician PEC and a nurse PEC. And it's found that if EMS or hospitals do have both a physician and nurse PEC, their scores are higher, and there is a notable association with scores and outcome. So what do EMS PECs do? So the goal is that they ensure the pediatric perspective is present in EMS protocols. They basically support, make sure that providers follow pediatric care practice guidelines, make sure that there's appropriate availability of pediatric equipment and supplies. They promote pediatric education. They can participate in injury prevention. They support the family-centered care at the agency. So, connecting with families who have children with special healthcare needs, or maybe a family in the community that is not English speaking, and kind of making sure that the agency is aware of that family and able to kind of be able to care for them and provide maybe pediatric specific protocols or needs. If that child has an emergency information form, making sure that's distributed to all the members of the agency, et cetera. Some of them even participate in some pediatric research efforts. And then finally, they oversee process improvement efforts, they support disaster planning, and they liaise with emergency department pediatric emergency care coordinators. Again, that connection so that there's feedback and follow-up and outcome information available to the EMS clinicians, that they know that that child that they transported did well. There's different models for PECs based on the type of EMS agency. Some models can include a shift PEC, which is a pediatric expert during a given shift. That person could be a resource for peers. And so I would say that in many rural communities, this might actually be the way to go. Oftentimes in rural communities, if there's either a heavy volunteer component to the agency, or when people work 48s and then they're off for 4 days and then back on 48s, they're not working during those 4 days that they're off. And so having one PEC per shift is actually probably more reasonable than having one person who's the PEC, but they're only on 2 out of 6 days. So that's just one thing to kind of consider. One of the agencies here in Colorado that I've worked with has decided to go in that direction. That actually really embeds, pediatric readiness across the entire agency and across the entire system at all times. Another could be just an agency PEC. Maybe this is somebody who's in a training officer role and might have a clinical shift reduction. This might be somebody who's already doing education, quality improvement, equipment in servicing and inventory, and other things. And then finally, there may be a role for regional PECs. And these are people who serve as a resource for multiple agencies, particularly if those agencies are small. And again, that may be really valuable in rural communities. They can facilitate training and resource sharing across agencies, and they can really be an important stakeholder in regional initiatives or organizations such as healthcare coalitions. This just shows kind of what surveys of our existing PECs actually do. And you can see the large majority of them are really involved in doing quality improvement, making sure that the providers are following pediatric clinical care recommendations. They're doing a lot of education, and they're making sure that pediatrics is part of the protocols. Very few of them are actually involved in research or other activities. Only about 50% were actively promoting family-centered care, and that's been a real focus of the EMS for Children program to kind of improve that. And getting back to this concept of skills, what you can see here is how we assess frequency of skills checks. The goal historically is that 60% of agencies would have a score of at least 6, and that basically is 2 skills checks per year plus 1 simulation per year using pediatric equipment. And what I will share with you here in Colorado, some of our scores, these are a little old, that our median score was a 3 in 2018. In 2021, our score went up to a 4, where about 38%, almost 40% of EMS agencies had a score greater than 6. Importantly, COVID really got in the way of being able to do this work because people were not coming in off of shift to do skills. They were really doing a lot of remote work, et cetera. But what's key to know is that agencies with a pediatric emergency care coordinator were 3 times more likely to perform skills checks at least 2 or more times per year. So they really are essential to meeting the goal that EMS clinicians feel get the chance to kind of practice doing skills with pediatric equipment. So I'll finish with pediatric quality improvement opportunities. Nationally, there has been a movement towards developing dashboards through the NEMSIS on the NEMSIS website. So NEMSIS, which is funded through the National Highway and Traffic Safety Administration, or NHTSA, and has a technical assistance center based at the University of Utah, kind of creates a general database for every EMS encounter across the country. All states have NEMSIS registries, NEMSIS compliant registries, and upload data to NEMSIS. NEMSIS recently has developed a series of dashboards. What you can see there is an example of the opiate use dashboard or opiate overdose dashboard. And so it allows states to kind of see how they are doing in comparison with other states and if they are kind of needing to put some processes into place. These dashboards that are currently in existence include heat illness, STEMI, stroke, other performance measures, transport and motor vehicle crashes, and some information around chief complaints. And now there is a set of pediatric dashboards, and this is a collaboration between the NHTSA Office of EMS and NEMSIS, as well as the EMS for Children program. So the dashboards, excuse me, I'll go back here, provide information about for example, of our critical conditions, like what % of agencies in that state are giving a medication for a certain clinical condition. States can actually filter these dashboards by geography of the agency, urbanicity, organizational status, are they volunteer, are they not, annual patient volume, and now actually even their pediatric readiness score. The institutional partners that kind of participated can be shown, here. There was a technical expert panel that came together to kind of develop a set of measures for pediatrics. And they analyzed these measures based on these 3 things. Was the measure relevant to pediatric pre-hospital care? Was it based on evidence? And is it patient-centered? And what they came up with were a set of 24 measures that you can see to the left. Airway management, there are 5 measures of airway management, 4 on trauma, including does the child go to the right destination? Did they get a blood pressure and a motor GCS score? There's 3 associated with pain control, 3 associated with respiratory illness, 2 associated with cardiac arrest. And then the others include anaphylaxis, et cetera, just some general different assessments overall. The pediatric dashboard, it is at the state EMS office and nationally, and there is a work being done that allows EMS agencies to try to be able to get a sense of where they are relative to the rest and be able to filter based on themselves. Right now, however, EMS agencies can use the information from the dashboard and then look internally by pulling their own data and examining and seeing if they are meeting kind of baseline requirements. There is work to do here. If you go to the NEMSIS pediatric dashboard, what you'll see if you click on anaphylaxis, for example, is only 30% of children with an EMS primary impression of anaphylaxis receiving epinephrine. So now you could argue that it's not very granular. That information is a meta level data point. It could be that some percentage of those children got epinephrine before EMS arrived, and therefore there wasn't indication to give it. But what we do know, again, from other data, is that children are routinely undertreated. And by starting to benchmark the state of things, it really does give us a sense of where we can go. That's a lot that I kind of threw at you. I just wanted to say thank you for having me here. I'm happy to take any questions while I've been kind of presenting. I can't really see the chat or the Q&A, but I'd be happy to kind of address any questions that anybody may have.
Again, if you have questions, feel free to put those in the Q&A box at the bottom of the Zoom screen. Thank you so much for sharing, Kathleen. That was wonderful information that I think benefited everyone here, probably.
Thank you. It was nice to be able to come and talk about this. So the number one recommendation I would have is if you're not familiar with your EMS for Children program or your program manager, they might actually just be down the hall from you if you're in a state office. Please, feel free to reach out to them. I think that they would love additional partners in this work. We're currently mid-cycle in our grant cycle. It goes till 2027. So there's a lot of work to do, and many states are using the data they're going to get on their pediatric readiness data to start to develop those readiness recognition programs. I hope I didn't go over, Rachel.
We've still got 3 minutes left, so you're perfect.
Okay.
Okay. Well, so far we don't have any questions in the chat. So thank you so much for your time, Kathleen. If anybody does think of questions afterwards, or if you would like more information about the Pediatric Readiness Program, you can feel free to reach out to Kathleen. Like I said, she has a lot of great articles as well. She posted her email address in the chat. So again, feel free to reach out if you have any questions. But otherwise, thank you so much for joining us today, and please enjoy the rest of your day.